So traditionally, these have been quite informal. We do encourage interchange. And I will say at the beginning that this is a very a dense amount of material to try to focus on what is new in myeloma. As you all know personally, the field was already quite complex, and now it's just become very complex. Now, this presentation will not include the basics of myeloma, the ABCs in terms of, what tests we do for myeloma, what are the response criteria, what's a bispecific, things like that. But you can refer back to our initial series that's on our website that goes through in a very, I think, user-friendly manner those particular topics, what tests we use, what's the standard treatment for a transplant eligible myeloma patient, a non-patient, what's a BiTE, how do CAR T cell work, but this presentation will not be at that level. I will just preface that, but I do welcome your questions for clarification. And I've tried to preface each topic with a bit of a background or context. There was a huge amount of information at this ASH. Some years there doesn't seem to be that much. But this year, I think we heard presentations that really herald where we're going in the future. It was astounding, I think, to someone like me who's been in the field for several decades now. So my main topics I selected for this were some new approaches to smoldering myeloma. We've really not talked about that on these seminars before, but I think we're going to be seeing not tomorrow, but some very dramatic changes. There was a really landmark study on the treatment of newly diagnosed transplant ineligible myeloma, a lot of activity about bispecific T cell engager antibodies and relapsed or refractory myeloma. And I suspect you already know we have teclistamab funded in Canada, and we still have easy compassionate access to another bispecific called enronalimab, and we don't have CAR T cell funded. We're still hoping to reopen negotiations, but I think people should know where we stand with that and what's coming on the horizon. So moving on, smoldering myeloma is a state that may be 10, 20, a few more percent of individuals go through on the travel from MGUS, which is just immortalization of one plasma cell making one antibody with no harm, 1% per year, will go to myeloma, and some pass through a phase called smoldering myeloma. Now, in this situation, the marrow has not less than 10% plasma cells, but at least 10% plasma cells, and this represents a little more active phase, so that 10% of people per year progress to myeloma, but not everyone over many years. Now, the hallmark is there are absolutely no symptoms or damage from the myeloma. And then, of course, we know about full-blown myeloma, which has also over 10% myeloma cells in the marrow, but also symptoms. I refer to those easily as CRAB, hypercalcemia, anemia, renal dysfunction, and bone destruction. Now, traditionally, the treatment of smoldering myeloma has been just to watch people, monitor them, and try to intervene when symptoms develop, but they're not too bad. But unfortunately, that means some people can be fine with one visit, and the next visit they have a bone lesion. Now, some people just have a little bit of anemia or things that aren't quite as destructive, but that has been the standard of care for forever. There are several prognostic scores that have identified people whose smoldering myeloma will progress to overt myeloma within 2 years. They usually describe the median time. So half of people more at that time, half of people are still stable. One of the challenges in picking out a group to treat is this prognostic score for what we call high risk smoldering has changed over the years. And you certainly don't want to jump into lifelong commitment of the disease if someone's going to be in the 50% that may go many years. So any treatment must balance the benefit of controlling the disease with the fact that any treatment will cause some side effect in a patient who's doing perfectly fine, even if it's coming into the doctors or the clinic every month. Is a disruption to life. Now, over the last 10 or 15 years, there have been a variety of trials that have looked at small numbers of so-called high-risk smoldering, including a transplant trial. And one that has been reported last year and led to the approval in the US and Europe for treatment of high-risk smoldering myeloma called the Aquila trial. And this trial takes daratumumab, the CD38 antibody, by itself and treats high-risk smoldering. And this is a curve of progression-free survival. You can see at 5 years, there's many more patients free of progression to myeloma, whereas about half the patients have progressed in that 2-year period, which is quite a good difference. And even though we usually don't see a survival difference with treatments that are this mild or this early in the study, there was a slight improvement in survival. Side effects, infection, 16% of the DARA, and just under 5% with the observation. And there was no difference in secondary cancers, which we need to monitor in all our trials. Now, I think what's interesting is the overall response rate was just about 40% for high-grade responses. So this is not a treatment that was designed to be curative. And I think if we talk about treating a cancer very early or a pre-cancer, do we want to control it or do we want to try to cure it? And I think that's one of the issues. Also, we want the treatment not to compromise anything downstream. Will giving DARA affect the activity of the next treatment? But so far that hasn't been panned out. So I don't think this is going to be approved in Canada. I don't hear about that. There are still unknown questions. But I think this is something an educated group should be aware of, because what really made a splash at ASH, if you will, is there was a small study that's still ongoing that combined daratumumab with one of the most potent myeloma drugs, teclistamab, the anti-BCMA bispecific antibody, gave it for 2 years. Now, again, high-risk myeloma had a bunch of definitions. They followed MRD negativity. But in the first patients, 100% responded, and all were MRD negative. So this is very different. This is getting rid of all signs of the disease within a year. What was also impressive is there was none of the immune serious side effects of giving teclistamab in this group, no cytokine release syndrome or the neurotoxicity. There were some serious adverse events, but if this pans out, um, I think this could revolutionize the treatment of smoldering myeloma. And we like to think we could cure cancers early. So again, we can't be too excited about 13 patients, but I think we all sat up and took interest at this. And I know Princess Margaret at least has been approached about considering a trial, not this one, but of this nature, in view of the fact we've been very conservative, kind of following don't do no harm, don't overtreat people that might go years with smoldering disease. But I think this definitely could change our whole algorithm. If we change what we do for smoldering myeloma, it's going to change everything downstream. So I thought it was worth bringing this to your attention. Now, what is more familiar to us is how do we treat newly diagnosed patients? And really, I don't think there was anything uh, highly significant about treating transplant eligible patients. We believe they should receive DARA RVD induction, transplant, consolidation with DARA RVD, and then Revlimid and DARA maintenance. And that is expected to produce a progression-free survival that is extremely long. But for transplant ineligible patients, and those are patients, this transplant ineligible has traditionally referred to age over 70, 72, and who are in a good shape, but also those who are younger and are frail and may have other major illnesses that we're concerned the transplant would just be too much. However, in some European countries, particularly France, the age cutoff for stem cell transplant has been quite fixed at 65 years. Um, and our Canadian standard, as I mentioned, has been higher. Now, we've treated these usually older individuals with DRD, that's daratumumab, Lindex, which gives, without a transplant, a median progression-free survival of about 5 years. And now Velcade or bortezomib has been added to RD, and so we now have a CD38 antibody plus VRD available through a compassionate program. So this is expected to give an even longer progression-free survival. So we have made progress in treating older individuals, but the PFS is not going to be 10, 12 years with the first line of treatment as it is with um, younger patients. So the French in Lille, a group with the National Trial Group of France, has done a pilot study for those over 65, newly diagnosed myeloma, a decent performance status, that gave TEC and DARA, the same regimen that was given to high risk smoldering. This is, they call, an all antibody based treatment. You notice there's no Revlimid, there's no bortezomib or Velcade, and the follow-up is not quite a year. And the goal, their first assessment was measuring very good partial remission rate. That's at least a 90% reduction in the myeloma protein after 4 cycles. Now, I think many of us had trepidation about treating older individuals with a bispecific antibody with immune side effects like CRS and ICANS, and that certainly can cause infection. So I think, again, there was a bit of reserve about this. But to move on to the results, this was not a obviously very mild population. The median age was 73 up to 87. A third were over 75 years. A significant number were considered to be frail or intermediate frail, over half. A third had bad cytogenetics, and another feature that we'll be highlighting at a couple of points in this presentation, disease outside the bone marrow, which is stubborn, hard to get to go in remission, and was also seen in a small number of patients. So when we look at the results, the response rate after 4 cycles was 95%. And if you looked at the group, the best response rate was 100%, and the VGPR or greater was 100%. There were no even just partial remissions, 50% reduction in the myeloma protein, and 67% had a CR, and if their marrow was studied a certain way, they had a stringent CR. So these are what we would call very deep responses. And if you look at MRD in the marrow, minimal residual disease, at a very sensitive level at 6 months, 100% had no sign of myeloma. MRD, we usually measure at 10 to the minus fifth, but we can do an even deeper search for myeloma in the marrow at 10 to the minus six. So these are practice-changing results. Now, again, these survival curves and progression-free survival, we never see curves like this in myeloma. 100% alive, well, without disease, at again an early time point. But again, these results are stellar. Now, what were the side effects? CRS is going to occur in patients. Grade 1 or 2 are really just fever or some milder side effects, and really very straightforward to handle these days. The other side effects were low blood counts, a few other in small numbers. Infection was 14%, which is what we saw in the first trial. And these were done during a time of COVID, these trials were. And so this risk, we think, will not be as severe as we move beyond the pandemic. No fatal side effects, and only one patient stopped treatment due to side effects. They had salmonella gastroenteritis. Now, one thing that will also be a theme through all these studies is these patients were managed optimally to lessen infection. And that means getting monthly intravenous gamma globulin, because these bispecifics get rid of all antibodies, not just the myeloma antibody, which reduces the risk of infection. So you can give other people's antibodies once a month, and preventative antibiotics, and patients were monitored for other viral reactivation. So these have been built into future trials and management of patients receiving bispecifics. And I think it's depleting the supply of IVIG. Hopefully the factories that manufacture it, which are not in Canada, will be able to keep up with the demand with these products. Now, what are the future directions? And again, I show this because it's where the whole bispecific field is moving, is to reduce how often teclistamab is given. From every 4 weeks to every 8 weeks after 1 year if the patient is in complete remission. And this becomes a much lower uh, treatment burden for a patient. And also, I don't have time to show this. It's been shown looking at laboratory parameters that this helps the T cells stay healthy to keep killing um, the myeloma cells. And now another subject dear to many of its heart with bispecific stopping the treatment after a time point. Now there's a balance because um, many of us have been treat until progression, treat and keep the disease uh, suppressed, and I have been one of those people. Like for maintenance, don't mess with it if it's working, but not with the bispecifics. The responses are so deep, you're suppressing all the antibodies, and I think one can stop it. Now, against that is against marketing. If you're going to stop, if your treatment's so good you stop it, well, then the revenue for the drug maker goes down. But hopefully, the studies will show that there is a sweet spot where you can get the benefit and stop the treatments. Now, there will be a randomized trial comparing this to, I'm not sure the design, DARA RD or DARA or ESA RVD. There's a T missing here, sorry, will be conducted. There's another arm of this study that combines tech not with DARA, but with lenalidomide, and we hope to see that soon. So I think the treatment for newly diagnosed transplant ineligible myeloma has taken a big step forward over the last few years, maybe taking a giant step forward with MRD negativity without any chemotherapy. So again, I find this really such a change in our approach to this disease. So now I'm going to move to relapsed refractory disease, and I'll start with bispecific antibodies. And again, to provide context, are what we use now in relapsed refractory myeloma, realizing that treatment depends on features of a given patient, what they've had before, and what their disease might have already grown through and is considered, patients are resistant to that drug, patient and physician preference, biology of the disease. But be that as it may, most of our Canadian patients nowadays have received Revlimid, lenalidomide, as part of their first treatment. And that's been the case for a while. So we really can't use Revlimid anymore. And the disease growing through Revlimid is a stumbling block because treatments after that are always a little less effective than if the patient has never had Revlimid, but Revlimid's such a good drug for that first setting. And many people now have received an anti-CD38 antibody, either daratumumab or isatuximab, with the first treatment. And now, if they haven't had it the first treatment, they've had it the second treatment. And of course, many patients have received the backbone drug, Velcade or bortezomib, back to the old Cyborg-D days, and these other combinations. So if a patient has never had a CD38 antibody, a decreasing population, we can use ISA-KD, less often Dara Velcade Dex, certainly third line, many provinces, second line, ISA Palm Dex, which is effective after Revlimid. So if they've had a CD38 antibody at the beginning, Dara or ISA, the options are not as good. Carfilzomib and Dex, with or without cyclophosphamide added, selinexor Velcade Dex, or pomalidomide oral cyclophosphamide dex. And then after 3 lines of treatment that have include what we call all 3 drug classes, a proteasome inhibitor, that is Velcade or carfilzomib, an IMiD, that is Revlimid or pomalidomide, and an anti-CD38 antibody. We are funded to give teclistamab, and elranatamab is a compassionate option. So that's the state of affairs now. So what are the new findings in regimens that contain a bispecific for relapse disease? And note that by provincial funding, we can only get a bispecific now after 3 other treatments, and then the patient has progressed. And then just to remind everyone about how a bispecific works, there is in our bloodstream lymphocytes called T lymphocytes that have the ability to kill cancer cells under certain conditions. So the drug is actually an antibody with 2 binding sites. Now, our natural antibodies, this binding sites against the same target, but in a bispecific, one arm brings the killer T lymphocyte, where the other arm brings binds to one of the surface markers on a myeloma cell. And the main markers that we have antibodies for are BCMA and GPRC5D. We also have an antibody, we have 2 that bind to CD38. That's daratumumab and isatuximab. But those are monospecific antibodies. Both arms bind to CD38. So it doesn't do what a bispecific does. It works, but it doesn't bring a killer T cell right next to a myeloma cell. And the killer T cell doesn't like BCMA or GPRC5D, so releases these toxins that kill it. And we call these bispecific T cell engager antibodies. They're abbreviated bispecifics, TCEs, BITEs, others. So the nomenclature can be a bit confusing at first. So I'm going to present the results of 3 trials. I think the first and the last are practice changing. The results of the first is called the TEC-3 trial, and several Canadian centers participated. The second is the redirect trial, and then the third trial doesn't have a name, but I'll talk about the tri-specific antibody in a minute. I won't have time to talk about some of the other ASH abstracts that I think were in many ways just as important. I've tried to highlight a bit of that before. So moving to less frequent dosing, giving treatment for a shorter amount of time, not till progression. I should probably add here really careful supportive care measures, IVIG or subcutaneous immunoglobulin, given regularly to our patients receiving these very potent antibodies. Plenty of prophylactic antibiotics against shingles and pneumocystis. These are really, really important, and early treatment of signs of infection. So what is the TEC-3 trial? And I put a gold star here because the results are so impressive. And this, again, using that word, will be practice changing. So if we go back to our schema of monoclonal antibodies, here is our myeloma cell with all these markers, and here is a killer T cell. So TEC-3 gives TEC and DARA, and so DARA sticks on to CD38. It's what we call a naked antibody, if you will, and it calls in all sorts of warriors to help kill the myeloma cells. But they're different mechanisms than TEC, the bispecific, which brings the myeloma cell next to the killer T cell. So there's a lot of attacking going on by different strategies. Now, the trial randomized patients who'd had 1 to 3 prior treatments. So this is early relapse. This is giving a bispecific, not fourth line, but second line on or later up to fourth line if people had had a proteasome inhibitor, that is Velcade or carfilzomib, and lenalidomide, and were reasonably healthy. If patients were refractory to DARA or ESA, they couldn't go on. They could go on if they were exposed, and they couldn't have had TEC before. So they randomized patients to TEC DARA or standard treatment, which was DARA Pomdex. We don't have that in Canada, but we have ESA Pomdex, or DARA Velcade. So they got DARA without TEC. And you can see that really a large number had only 1 prior line of treatment. A third had high risk antibiotics, and 14% had extramedullary disease. So what were the results? Sorry, this is a bit out of order. So the results were really quite stellar, so that at 3 years, 83% of the TEC DARA patients were free of disease. And this is starting to look a bit like CAR T. Although people are getting continuous, it's not a one time. Whereas the control arm, this is what we have now, only 30% were free of disease. The median benefit, progression-free survival with what we have now is typically a year, and here a year and a half. So this is a tremendous improvement over what we've had before. And again, we're seeing very early in the trial a survival benefit for these patients. So again, we have to look at the other side of the coin. Teclistamab's a very potent drug. It has a lot of side effects, but we've also learned a lot about how to give it and how to make it safer. So here there was no high-grade cytokine release, a very low incidence of early neurotoxicity. The rates of stopping the treatment, which is a really good way to see how toxic it was and if patients started refusing to take it, was almost identical. 4.9 for TEC DARA and 5.5% for the standard of care. Now, there were some deaths not due to myeloma, but they were very similar. Infections were quite high at the beginning. This trial was active right at the beginning of COVID. And the grade 3 or 4, that's more severe infections, was high in both arms. And unfortunately, COVID was in grade 3 or 4, COVID pneumonia was in over 10% on the TEC DARA arm versus 2.4% in the control group. But when they added IVIG monthly to give patients more antibodies circulating, and again with these rules for giving prophylactic antibiotics, this risk of infection has gone way down. Again, that lesson of how important it is to do the supportive care measures. But there was a definite survival advantage. And, we have to follow longer, but you can see, we like to see what we call a plateau in the curve. No one's relapsing or passing away after kind of 3.5 or 4 years. So again, I think this will give um, um, CAR T cell, it will give an option to CAR T cell, or at least a run for its money. Now, the I'm starting the theme again of giving bispecifics in combinations. We have single agents available now, which is a big deal, but the future is definitely combinations. So another trial that was updated is called the Redirect trial in myeloma, and both the TEC3 and Redirect have been done in Canada, so there may be people in the audience or people that have had these trials. Excuse me. But what Redirect did is give two bispecifics. The first one we've talked about multiple times, TEC, and the other one that's approved by Health Canada, but unfortunately not funded at present, is talquetamab, which recognizes another surface marker, not BCMA, but GPRC5D. Now, these patients had to be triple class exposed, that to be eligible, that means they had to have had um, a PI, an IMiD, and a CD38 antibody. And the trial was really looking at trying to find something that would be better than what we've had in so-called extramedullary disease. Now, extramedullary disease is really a clump of myeloma outside the bone marrow, and it could go anywhere. This just shows skin. And even though the clump or the deposit may be quite small, its biology is potentially very serious because it means the myeloma has learned to leave the bone marrow, and that's not good. It can go a number of places. Now, this trial was not comparing this two bispecific regimen to a standard of care. It was just what we call a phase 1 trial, where they kept increasing the doses of both in a designed fashion to try to find the best combination in terms of how well it worked and how safe it was to study more. So this is what they found. At the dose that they thought was the best balance of how well it worked with side effects, what they call the dose that they're going to use for phase 2 trials, the overall response rate was 80%. Now, when they looked at the results in individuals who did not have extramedullary disease, it was 92%. And these were patients who were pretty far along. And you can see having extramedullary disease reduced that, but it was still pretty decent, 61% for this hard to treat group. Now, each of these bispecifics has its own side effects besides CRS and ICANS. We've talked that TEC can certainly lead to risk of infection. Talquetamab has these peculiar side effects because the target is on the skin and the lining mucosa. So there can be rashes, there can be oral lesions, loss of taste, bad taste that leads to weight loss. The nails can get cracked and crumbly, and they're not life-threatening, but they're certainly unpleasant. So the toxicities of each were seen. The infections, 43%. Now, what to me was a bit of concern was the really weird infections was 17%. And there's a particular kind of infection called PML that is a virus that wakes up in the brain. And it is we've only seen 3 cases of this at Princess Margaret. We wrote it up. The problem is, even though individuals can get better once you stop the treatment and the immune system can get back into action, but one can never treat the disease again because anything that lowers the immune system, any treatment will make it reactivate. And it's the brain. So it's like having symptoms of a stroke, and it can be quite severe. And also, fatal infections were a bit over 10%. Now, again, this was during COVID, and that increased the risk and severity of infections beyond what we see now. But again, this theme at the beginning, when these trials were started 5, 6 years ago, IVIG, COVID vaccines, and prophylactic antibiotics were not recommended at first. So we have to take that with a grain of salt. So this is likely to be studied further, but I think what it has led to is an even more sophisticated strategy of what we call tri-specific antibodies. Usually antibodies have 2 prongs with 2 binding sites. Now, many companies have created an antibody with 3 binding sites. So one attracts the killer T cell, and then here one attacks or targets BCMA and the other GPRC5D. So instead of giving 2 different antibodies, the targets are all brought together and packaged in one antibody, and you bring the T cell there. So this is really cool. Now, there several companies have this. These are coming into Canada fairly soon on studies. And this was reported a first in man study of one of the products. And again, this was phase 1. They studied different dose levels, but these were very heavily pretreated patients. All were triple class exposed, had all 3 main drug classes, and 28% had actually had a prior CAR T. So what was the overall response rate? Was 83%. Those who had extramedullary disease had a response rate of 80%. Remember, giving the 2 together was 60.1%, the 2 different antibodies. And if someone had had prior BCMA or GPRC targeting drug, they'd already had antibody treatment against these, the response rate was still quite good. Now, this trial, built on the learnings of the other ones. The grade 3 or 4 infections was much lower at 28% because there was liberal IVIG use. And there is a sense that the skin and mucosal side effects of this target weren't as bad as tau alone. So this is a really attractive strategy because you could combine this one drug with DARA, with POM, etc., and you're just giving one drug instead of multiple IVs. So I think again, this is a big step forward, and we're about to see the generation of many trials to study these. So if I summarize um, sort of my take-home messages about bispecific antibodies, particularly drawing from ASH 2025, we are in the era of combinations. And you can have all sorts of combinations, bispecifics and DARA or ESA, and really TEC3 rivals all other treatments for first relapse. You can put two bispecifics together. You can put two targets into a single antibody. There's your trispecifics. I have not presented any data, and there wasn't there wasn't really good mature data of bispecifics plus oral pomalidomide, or even in newly treated patients where Revlimid might be used. We'll be seeing those trials in new diagnosis in the future. Really, routine IVIG or subcutaneous IG is essential with these treatments and prophylactic antibiotics. Reduction of side effects is critical. And we are working hard to get these treatments into our Canadian patients. Now, I just was going to highlight a couple of trials that are ongoing at Princess Margaret. One is a product of a tau-like GPRC5D bispecific that's enhanced for efficacy, but I think one of the really exciting ones will be giving the anti-BCMA antibody elranatamab, and I apologize, I misspelled it, plus an oral, not an IMiD like pomalidomide, but a CELMoD, which is the next generation of those oral drugs, which is many more times potent, and the most potent of all is mezigdomide. So there's a bite with one of the best single agents, and this trial is now accruing at Princess Margaret. I am very excited about that. So I'll move on now. I have to look at the time to a brief update of CAR T cells. Now, the two abstracts I'll present out of a number are strategies to reduce side effects of cilta-cel and some updated results on one subset of patients receiving cilta-cel. And then at the end, I'll close with a little bit about the other CAR T cell products that are coming, that have trial data and either are coming into Canada or trials, or will be coming in to Canada. Because I think that's the question everyone wants to know, is when can I get a CAR T cell treatment? So the sort of the baseline of cilta-cel excitement came from the CARTITUDE-1 trial, which had patients that had had a median of 6 lines of treatment and were very heavily pretreated. And the updated results show that a third were alive and progression-free at 5 years, which is phenomenal. Now, we have a lot of side effects to try to deal with early. Cytokine release syndrome, neurotoxicity, and a rare inflammatory condition that can be problematic. Delayed, the incidence isn't high, but it can be have a great impact. One of the ones we're most concerned about is delayed neurotoxicity. And this usually shows itself as a type of Parkinsonian, either with tremor, slow movement, or cranial nerve palsies like Bell's palsy, or peripheral neuropathy. And this may, particularly the Parkinsonian, if it comes, it may not reverse. So patients are stuck with another chronic disease. And more recently, a bowel inflammation, colitis, has been recognized. And then later on, we're monitoring second cancers and other effects. And then there is a risk throughout the duration of persistent low blood counts and infections. Now, if you look at the several studies about what are the downsides, the upsides are quite clear. This table just goes the background. There was a US real world study, Cartitude 1, and then Cartitude 4, which was the study that treated patients earlier in the disease course with cilta-cel after 1 to 3 prior lines. So you can see this delayed neurotoxicity is quite consistently about 10%. And the cranial nerve palsies may reverse, but the Parkinsonian, it's not a huge incidence, but it's an important one. Now, the other aspect we're monitoring, and this was certainly done for stem cell transplants, what we call non-relapse mortality. That is, a patient passes away or dies from a cause other than myeloma. Now, usually that's due to a toxicity. It could be someone got hit by a car, but it really reflects um, a fatal side effect. So there was a real world analysis of cilta-cel at this ASH that was over 750 patients. These were all comers. They weren't trial patients. It gives an idea of when you move it out of a carefully controlled population, what do you get? So the overall response rate, and these included those treated early and late, was 92%, CR rate 72%, and at 1 year, the progression-free survival is 72. But the focus was really looking on neurotoxicity and non-relapse mortality. So you can see the early immune toxicities were quite similar. CRS is very common, rarely fatal. ICANS was usually grade 1 or 2. Infections, high-grade infections, 14%. Any delayed neurotoxicity was seen in about 10%, and again, Parkinson, cranial nerve palsies, and other. Looking at the fatal toxicity, year 1 was about 10%. Now, for comparison, a stem cell transplant nowadays is 1.5%. So that's still a number that we would like to bring down, obviously. So what was the bottom line in this study? What were the risk factors for Parkinson's disease and non-relapse mortality? And there were some potential findings that potentially would allow so-called mitigation factors. The first is the majority of patients, while waiting for the T cells CAR T to be made, which is several weeks, these patients are progressing, is giving what's called sort of bridging therapy. And the concept has become more analogous to a stem cell transplant. It's like induction therapy. The treatment you get to reduce the amount of disease before the whammy, the CAR T or the stem cell transplant. And if that bridging therapy did not result in at least a partial remission, there was 10 times the risk of Parkinson's disease. Now, it's still low, but we really want to get rid of this. So also, this having good bridging therapy reduces the tumor burden. And we also use the term debulking, also reduces that 10% non-relapse mortality. So having better induction before the CAR T cell is a step we could really work on, and we have more effective drugs. The other finding that's finding its way already into a preventative strategy is they looked at a number of factors and found that sort of in the first 7 to 14 days, many patients have a rapid increase in the CBC of the total lymphocyte count. Now, usually we're worried about neutrophils that directly fight infection or platelets that clot the blood. But if the lymphocytes shoot up they're normally, very low after getting the lymphodepleting chemo. Normally they're 2 to 3 in our units. If they go up to 3 or greater, that's associated with a very high risk of Parkinsonian symptoms. That's 12%. And what we think is those lymphocytes are actually the CAR T cells that are really taking hold in the patient. And that's when the damage occurs to the sites in the brain that cause Parkinson's. So that rapid rise in lymphocytes so early into the course can be the time to intervene. And you don't want to kill them. That's probably, the CAR T cells that are killing the tumor. But there's already work that you can give dexamethasone. Steroids really knock down the lymphocyte count, whether you're giving steroids for poison ivy or asthma. So intervening with dexamethasone to mute that rise, which is pretty cool because that may, again, find the balance in how to prevent this frustrating side effect. So I think we're making progress on this front. The message is debulk the tumor, then you don't have as many cancer cells to kill, you don't have as many chemicals released from the dead cells that triggering all these other reactions. You don't have as many cells to damage the part of the nervous system that causes these effects. So the last 2 slides or 3 slides, there were several presentations about cell-to-cell, but we're going to potentially be in a situation because everyone could be a candidate for cell-to-cell who's relapsed 1 line of treatment. So there's no way we anticipate being able to treat everyone. Now, the good news, there are these alternatives coming up. And as I'll discuss, there's alternative CAR Ts coming up. But we need to tell people, hopefully, rather than having to decide who can get CAR T or not, that would be a terrible situation. We at least need to be able to tell people more of what their outcome is. And I've just focused on standard risk cytogenetics, no 414, 1416, or 17p. This abstract looked at those patients in CARTITUDE-4, response rate 100%, CR 90%, and at 3 years, 80% are still free of progressive myeloma. And here, no Parkinsonian, and the other side effects are very expected. So this group does very well with CAR T after 1 to 3 prior treatments. So what's the status of other CAR T cells in relapsed refractory myeloma? I've mentioned 3 other platforms that are creeping up on cell-to-cell. The first is anito-cel. It targets BCMA. One of the attractive features is in the initial study, there's no delayed neurotoxicity. There may be the ICANS, which is generally mild and reversible and very low incidence, but none of these other more debilitating ones. So there is now a randomized trial comparing anito-cel versus a standard of care that's ongoing in Halifax, Ottawa, McGill, and Princess Margaret. Now only half of people get anito-cel, but it's 1 to 3 prior treatments. And individuals have to have had a prior IMiD like lenalidomide and a private CD38 antibody, either DARA or ESA. There's Arlacel, which is targets GPRC5D like tau. The first trial is the quintessential trial in Calgary and McGill only. This is phase 2. Everyone gets Arlacel, at least 3 lines, and need to have all 3 big groups. And then there's Quintessential 2 in Vancouver, Halifax, Maisonneuve, Rosemont. This again is a phase 3 trial of Arlacel versus the standard of care. And it's 1 to 3 prior lines, including the 3 drugs, and prior lenalidomide is required. And then Calgary and Princess Margaret have a trial that's Arlacel being combined with a variety of other agents, ranging from a BCMA bispecific to, I think, combining it with IMiDs and CELMoDs, so it's not a single agent. Now, there's also another one coming out of China called Equicel that targets BCMA. Its initial study, again, showed no neurotoxicity. And this manufacturer is already reaching out to us in Canada about how to get the drug or the CAR T platform into Canada, because we have this huge gaping void. We have no CAR T cell that's widely available. And I think, I'm not in the know, but one of the big pushbacks and why we're in this conundrum of not having CAR T is the price. So one wonders if any or all these offer a lower price. Hopefully we will get more than one CAR T product as soon as possible. So in summary and conclusion, you can see we have just rapidly increasing options. I think we're nudging towards a cure. I've been very hesitant to say that, but I think seeing these 100% CR rates and MRD negative rates is quite amazing. We're moving bispecifics and CAR T even earlier. Combos are the future. We really have to focus on ensuring infection prevention, and certain keys to enhancing the effect of CAR T is getting bridging therapy to really knock the tumor load down, watching for a rapid rise in lymphocyte count with cilta-cel, and that's being adopted in other CAR T products too, and refining prognostic factors to see who will do best with CAR T and who will need another agent added, like one of the studies I just mentioned, and that we do have CAR T options coming to Canada. It's not fast enough, but they are coming, and CMRG and other stakeholders are working very hard to try to get this as soon as possible. So I'm a little bit over the hour, but those who want to ask questions, I'm happy to do my best to answer them. Thank you.
Thank you so much, Donna. This was so awesome, and I'm so happy we have so many people joining. If anyone has any questions for Dr. Reese, please feel free to send them in the chat or come off of mute. If you don't feel comfortable, you can absolutely send us an email. And even just for any feedback and anything you guys would like to learn about for future webinars, we'd love to hear from you. So yeah, definitely open the floor to anyone that would like to ask any questions to Dr. Reese, whether related to this presentation or anything.
My goal is always that it sort of makes sense.
Hi, can you
Very
hear me?
complex field for sure. Yes,
Hello?
Tracy? Yes, we
Yeah.
can hear you. Go ahead.
Sorry, I just tried to do a chat and it said chat was disabled. So
Okay. Sorry about that.
no worries. I only see my oncologist every 10 weeks right now. And but I watch Zooms and I'm part of different groups that I watch for stuff. And in the States, obviously, there's a lot more options. And I know that Myeloma Canada, we just did a big letter effect in regards to the CAR T. And I had posted on one of the sites that we didn't have CAR T, and I available, and I just got hammered by, well, my husband just had it in Toronto, and my whoever did this in 2025. Is it just it's not widely available, or is it just not available at all, or is it just special stuff? They said they weren't part of studies, but so I'm a little confused. Do we have CAR T? Do we not have CAR T? Do we yeah, so any
We we do not have any CAR T funded, and if I could make several comments. One, CMRG has also sent a letter to every healthcare lead in every province
okay.
supporting this. And we have a different angle. One could argue having different big groups is also important because we come from a different angle. We sent a letter to specifically to the health minister and other individuals of each province and territory, as well as PCPA, and did get an acknowledgement that they'd received it. So at least it was received. And it did strong again highlight the efficacy, the lack, the unmet need, and the importance of having this. Um, I may be a little bit out of date, and I am at the door for this, knocking, but I was sobered by the fact that only this was like a little before Christmas, only 14 countries actually have still-to-sell available, and several of them it's only for private insurance in the
Okay.
UK and one or two of the Europeans. So it's not universally available. I think the only one that is broader is the US. And so that was shocking to me. Um,
Okay. Well, one of the groups I'm in, it's Myeloma Warrior. So it's mostly the States. A lot of other
oh yeah,
people from other countries are there, but it's mostly people from the States.
yeah.
And I
That's
even know that the letter in December that we sent the MPs and blah 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 was for Cardivic.
yeah, I call it cell to cell because I
Oh,
Cardiff,
is it the same thing?
it's the same thing.
Okay. Well, thank you. I'll go off mute
No,
and
no, but the other point is right now there is no compassionate program. So it is only through a trial. That's why I listed those trials. Now there are more trials coming up, and these other companies are moving in, but that still doesn't give funding for all the need. And the other side of the coin is with all the um, hangover or the impact of COVID, you have to have a really good infrastructure to take care of these patients and staff. And it's, even if the doors were thrown open, that it was funded for everyone. I don't think the uh, I want to be careful. It'll be very hard to meet the demand because a few more beds are opening it up at each site, but those are the beds that are used for stem cell transplants
Yeah.
and CAR T for lymphoma, which is standard of care and well funded. So there's a resource issue. But now people can go to the States. I may get it wrong. For $1 million, you can go to Buffalo or someplace and pay for it yourself.
No, they
Um,
said these people said they weren't part of the trial. One was in Toronto, and I think one was the person said my husband was saved by CAR T in 2025. It was not a trial. But I'm like, okay,
it,
I must be mistaken.
it,
But
there is. I'm director of the Princess Margaret clinical trials program, and there are no CAR Ts that
yeah,
are not clinical trials. Now, they may not, the ones we like are the ones without a coin flip. Everyone gets the CAR T. So I would wonder if that is, it's not a trial where you can't decide. Everyone gets it.
yeah,
Uh, and now the trials that we're starting to see, some of them, um, they to get it really permanently approved by the regulators, you have to show it's better than what we have, even though we know it is. You still have to show it. So
okay,
I'm really wondering if that is there wasn't a coin flip. It was given, but
yeah,
there's no funding because these are $1 million list price per product.
wow, okay, thank you. I just wanted some clarification. I thought
Yeah,
maybe I was
absolutely.
mistaken, so thank you.
Absolutely.
Dr. Reese, we have a question from Joanna asking, how is extramedullary disease detected?
Yeah, by that's a very good question. Um, it we don't necessarily routinely screen for it. We go by symptoms. Um, so, if it's something obvious like a lump on the skin, it can also be like a lymph node. If there's a big lymph node somewhere and you biopsy, a PET scan will pick it up. And we're generally doing PET CTs for newly diagnosed myeloma patients, and one has to suspect it to order another one. It's kind of any way you find a tumor lump. If it's internal, you may need a CT scan or a PET scan. But what triggers ordering those scans? Since it's not bone symptoms, it's usually there's some symptom a patient has that you do the imaging. Occasionally, it's just feeling it or looking at it. If it's skin, you see a nodule go away. It's not the majority of people. Most studies may have 10 or 15% with relapse disease. It's usually not there at the beginning unless someone has plasma cell leukemia, where it's myeloma, but the myeloma cells are in the bloodstream and you can see them readily. That's a form of extramedullary disease. It's outside the bone marrow because it's in the bloodstream.
Awesome. We have a few more questions coming through. Another one is from Yolanda. Thank you very much. What do you think of in vivo CAR T?
Oh yeah, it's I know, and I'm going to show my ignorance because I haven't concentrated on it, but I think somehow you and Yolanda, hello. um, I think uh, you don't take the T cells out of the body, you transform them into attack cells in the body. I think it's fascinating, and there are scientists and companies working on it. I think it's a while off, but anything that avoids taking the lymphocytes, T cells out, and taking 6 to 7 weeks to rejig them so they attack myeloma cells, anything that will shorten that, because a lot of things can happen between when you collect them, and then you can finally treat the patient. Patients all have active disease. They get worse. They can get sick. They can get other illnesses. So anything that will shorten that. There are some CAR T programs that are generated in a week, but those are still not quite ready for prime time. But that's another generation.
Awesome. Another question from Jillian. Does teclistamab treatment preclude CAR T or just certain kinds of CAR T?
The data, so the answer is right now, the wording is yes, it does. That's wording from CADITH CDA. The studies now show that getting a BCMA targeted antibody before a BCMA targeted CAR T, the CAR T doesn't work nearly as well. So I think the thinking is, if you're going, and there aren't a lot of studies, but if you're going to use a potentially toxic $1 million treatment, you don't want to set the cards against it working. Now, using bispecifics after a CAR T seems to be a better strategy, but I think some of it depends on the target. What's being done in the US is for bridging. Let's say you're going to use cilta-cel, targets BCMA. It's all very well and good to say you need good bridging treatment to really knock the tumor down. But for many of these products, you already have to have gone through all the effective agents. So you're not left with something you can give for 2 cycles that's really going to knock it down, because the disease has already grown through things. So some people are using talquetamab, tau, which targets GPRC5D. It's a bispecific, before giving a BCMA CAR T. Now, just to, really blow your mind, there are CAR T strategies. One of the protocols in at ASH from China gave 2 different kinds of CAR T that targeted different things in a certain sequence. So, we want to go after as many vulnerabilities or targets on the myeloma cell. So all these strategies are up for evaluation. But then we have what Kadith says, which is you kind of right now, and I think it will definitely change as more data comes out. You can either get a bispecific or a CAR T, except you can get a bispecific maybe after CAR T, but not before. I'm not making myself very clear. But we are restricted because of cost and lack of data.
We have another question from Liv. There's a few more questions. And if we don't get to everyone's questions, if they keep coming through, then absolutely you can send us an email and we'll make sure to tailor to future webinars. Absolutely. But from Liv, she said a friend just received CAR T for non-Hodgkin's lymphoma where the cure rate is not as high. Why is it approved for non-Hodgkin's, but not for multiple myeloma?
Um, I must admit, I don't know the cure rate for CAR T and Hodgkin's. Um, I don't know if I know the provinces approved CAR T for certain lymphomas and fund it. The reason is it's curable, it's curative. Um, Now, many lymphomas are cured with regular chemo or with their monoclonal antibody rituximab. So it's a curative disease in many instances where myeloma has been a very hard nut to crack. We've been able to control it, but reliable cures have been very hard to achieve. In fact, people talk about functional cure or aspirational cure. I mean, cure means you live your normal lifespan out, and I don't think that's been a comfortable thing to tell people that we can achieve. But Hodgkin's disease is highly curable with other strategies. So I think even if the rate is low, the fact that you can cure something versus keep it gone a few years before it comes back is very attractive to the funders and, of course, to everyone else.
Awesome. And then we have a question from Jane. Thank you, Dr. Reese, for your presentation. Are the alternative CAR Ts available to patients with a 17p deletion?
Oh, yeah. Yeah. I think it's all those treatment we don't deny someone with high risk disease, and it gets tricky. 17p in myeloma cells by fish cytogenetics picks up missing that gene, or it's not active. But of those individuals, only 10% who have lost their other 17p or it's mutated are really high risk. So of 17p deletion, 90% are not high risk. So you can tell this gets under my skin. Doing fancier tests to look for mutated 17p or both loss of both alleles is what's really high risk. And this drives me nuts because I know in earlier years when you try to give an individual an idea, is their myeloma going to be harder to control than someone else's? We don't have a crystal ball. You can't say exactly how long, but I think, we try to reassure patients or alert them we're going to try to do extra to take care of a disease we think is going to be harder than average. What if we're giving them, we're either scaring them or reassuring them if our tools of prognosis are not accurate. And the 17p is very important because losing both of them or both of them mutated is a very stubborn disease. But just the way we measure it by fish doesn't give you the bet. You have to look at gene mutations and double loss and things like that. The same goes for 414. It's only 25% of 414 patients who actually have high risk. Now, they drive the whole group that they don't do as well, but the other 75% are standard risk. So that you can tell this gets under my skin because you want to give people accurate information. But anyway, we'll get there with whole genome sequencing and these things that are coming into practice. They're all expensive, they're complex, but they are used in other cancers, these tools, and we are pushing to get them into myeloma. And we're studying this at Princess Margaret too for newly diagnosed people with if they have 17p or 414, we're doing all the other studies to try to accurately figure out, are they really high risk? But that isn't known for a bit of time.
Awesome. Okay. And then we have a question from Nina. Nina asks, what are the symptoms of neurotoxicity years after CAR T? She mentioned that she had CAR T in Buffalo in December of 2023. Is there a possibility that it could show up 3 years after?
Hi, Nina. um,
Hi,
uh,
Donna.
actually,
So
that,
Philip McCarthy says hi.
oh, yeah, please give him my regards. He's one of the funniest people I've met.
Yeah.
Um, that would be unusual. When I was preparing for this talk and looking at sort of the real world data of Parkinsonian and delayed neurotoxicity, it was the median onset was about day 30, and the
Okay.
latest was 7 months. So I think, you know, that length of time should be home free.
Okay.
The
Yes,
damage
this.
occurs at uh, at the beginning, even though the symptoms may be later. I mean, I think it gets complicated. Parkinson's is on the rise,
Yeah.
um, anyway, and in men, and I know they've determined that certain agricultural products like Agent Orange and dioxin killers and other things have a toxic effect that, or even the older, I think, dry cleaning chemicals can damage that part of the brain. So are we just, there's no data for this, but you know, are are we heaping more damage on a vulnerable part of the brain that's already been insulted by all our environmental toxins that we're now realizing maybe worse than we thought anyway?
Yeah.
But I think, several years it would be unheard of.
Okay. Good to know.
How are the ski slopes?
These slopes are great. Um, we've traveled a lot, and to be honest about like it was Carvicti that I got, I paid for it. It was not $1 million. It was less,
Good.
and it was easier than a stem cell transplant.
Yeah,
Like
I think
zero
that,
side effects for me anyway.
yeah, I think um I think in general the myeloma CAR Ts have had less CRS and those immediate, rather dreadful fevers than lymphomas.
Mhm.
Um, and it has allowed these CAR Ts to be done in fit people into their 80s, which is not the case with stem cell transplant. So we'll
Yeah.
see where stem cell transplant goes. It really was a workhorse treatment for several decades. And, as we refine the immune therapies, I mean, I think it's fascinating that back at the beginning of this, that in transplant ineligible with two antibodies, uh, you can have 100% MRD negativity. I no 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 weed killing. I think of chemo as weed killers. The weeds are the myeloma. They're chemical weed killers. And then we moved
Yeah.
into the smarter drugs like the IMiDs, like Revlimid and pomalidomide. That's not chemo. Uh, and even Velcade or bortezomib is not a classic chemo. It inhibits an enzyme system and a whole bunch of other cellular functions. So we sort of moved into that non-classic chemo, non-weed killer era. And now we're like in antibodies and cellular therapy without weed killers. It's all in a very short time frame.
Which is good.
Oh, all good.
All good.
All good.
We have a couple of more questions. There is a few questions I think that are more tailored to individuals' experiences with specific treatments. And I think before we go into, and honestly, Donna, correct me if I'm wrong, I think everyone wants to know if a treatment will, work for them and how long they'll be able to stay on it and what happens if you have poor side effects to a treatment, how will that affect your future treatments and everything like that. Like Paul is saying, if you're on lenalidomide and you became allergic to it, does that affect treatment down the road? And I think, again, Donna, correct me if I'm wrong, I think obviously there's no one treatment that works right for everyone and everybody responds differently to treatments, and it's very dependent on the individual to certain degrees, even though we see statistics and everything. But what and Donna, again, if you disagree or any thoughts about specific treatments, obviously everyone has their own disease and their own story that they're going through. But with Paul's question in mind and some of the other questions about treatment specifics of consequences of, being on a specific treatment, how long it will last, or what happens if you have a side effect and you have to come off of a certain treatment. Specifically, Paul's question, if you're on lenalidomide, if you became allergic to it, how does that affect treatment down the road for you? Kind of what are your thoughts on that?
Yeah, there's a lot that can be done to get around individual reactions. Now there are people that are allergic to lenalidomide or Revlimid. There are desensitization programs. We have published on one 2 or 3 times for our experience with Princess Margaret. Um, it's rare that someone absolutely can't get a drug again. It does happen. And by the way, someone, and I have to look back up, asked me that they had a real reaction to cyclophosphamide, which is one of the lymphocyte depletion drugs you give before giving CAR T. And the concern was absolutely not being able to tolerate cyclophosphamide, which I've only seen in one other person in my whole career who got a really high fever every time they had oral cyclophosphamide. But there is an alternative. I finally found that out. So for lymphodepletion, if one can't take cyclophosphamide and fludarabine, bendamustine can be used. So, but there are ways. It's rare that you can't get around intolerance to one drug and design a variant. So I don't want to speak where I don't know the details, but it's been rare that we couldn't come up with something good. I did have an individual who had horrible reactions to Dara and Issa, I believe, absolutely couldn't get it, had anaphylaxis practically, but did respond beautifully to Belamath. So, these are one-offs. So I don't think all is lost. I did see a question
Absolutely.
about when we thought cure would be here.
Yeah, I was gonna say I feel like a great question. We can maybe finish with that one, Donna, and your thoughts on, and time frame for a cure. And then obviously, if we didn't get to everyone's questions, then again, please email us. I can put the email in the chat. It's just cmrg@cmrg.ca. If you have any feedback or any other questions that you'd like answered at future webinars, we're happy to incorporate those. But I think always as we're going through, and again, kind of bringing back to what I was saying before, everyone's situation and journey is very different. And obviously, everyone responds differently to treatment. And, you know, being in this world, even myself being exposed to it, it is so complex, constantly evolving. And I think obviously, you know, you're a physician, and if you're a patient or if you're a caregiver, the physicians are the ones that know the details of your treatment and obviously will inform you on their best thoughts on how to move forward. And obviously, we want to share what's going on in the fields, but always refer back to your physician with any sort of you know, decisions or thoughts or anything. But yeah, Donna, what are your thoughts on a time frame for a potential cure to end it off?
Well, I think the I think we're on the cusp of seeing it. I think the proportion will depend on how far along the disease is. And again, the definition is one lives, it's not a 5 years without disease, like people have said for lymphoma or leukemia. It's you live your whole life out. So you can't say that ahead of time. Um, but I think we are already seeing disease control for years for an increasing proportion of patients. I think using MRD as a marker of a deeper complete response, seeing those 100% rates at diagnosis, if that stays, you know, people may be cured, but monoclonal antibodies eventually are cleared from the system. Will the disease wake up then? I think the same thing. I'm talking in circles, but CAR T cells for myeloma don't live that long. You know, they don't last but a few weeks or months. Now that's fine in lymphoma because you can blast it and then go home and it's dead. And that's why it's cured with regular chemo so well. But with myeloma, you blast it, and these are very plasma cells are very resistant to killing. When I was undergoing training, I remember my mentor saying, when we used to use high-dose chemotherapy and whole body radiation before a stem cell transplant, when another person was a donor, and we used, you know, like for leukemia and the so-called allotransplant, if you sampled the marrow 2 weeks later, and whole body radiation kills off everything in the bone marrow. If you do a bone marrow 2 weeks later, the only cells that are left in the bone marrow are fat cells, sort of network cells, and some plasma cells. They haven't died. So these are really, so all your leukemia cells, your red cell making cells, your normal white cells, they're all wiped out. But you see some plasma cells, some mesenchymal cells, and fat cells. So it's a very stubborn cell to kill. But I think we're on the brink. And I think probably CAR T may be followed by something in certain patients treated early. Will give the highest cure rates. And then, you know, if those CARTITUDE-1 patients that were, if they hold the very resistant disease holds for 10 years, they're probably cured. So I think we may be seeing a few people now that are cured, but the proportion will depend on how far along the disease is and what combination of treatment. I don't think we're like we can say with lymphoma that when someone is diagnosed that you have a 60% chance of cure. We're not at that point yet, but we're close. Also, I know that doesn't completely answer the question, but these are words I never said before because I really didn't think we could get rid of the cells. But Vanessa, you should introduce who you are.
Sure. Okay, sorry guys. I think I joined a couple minutes late. I didn't have a chance to introduce myself at the beginning, but my name's Vanessa. I'm a clinical trial specialist at CMRG. So I am currently leading two of the CMRG sponsored trials. I'm actually on a monitoring visit right now, joining remotely outside of the GTA. But yeah, I love to get involved with, patient outreach. And that was one of the, primary focuses in my last position. And, with managing the clinical trials and working with a lot of clinical trial sites and everything like that, it is really nice, obviously, to get involved with patients and get feedback from patients and, really contribute back to the community. So I love working with Donna, obviously. She is fantastic, very brilliant. I learn something new every day working with Dr. Reese. And yeah, we would love to continue these webinars. And again, if you guys have any feedback for us for future topics you would like to learn about, we would be happy to tailor it to what you guys would like to hear about. But yeah.
Thank you. Yeah, Vanessa's joined us, and we've got a very young, motivated, smart team in the office. So we're continuing to work on your behalf. I can't emphasize enough. We did, I think, 12 of these seminars, and then had a long hiatus. It's really important for us to know what you want to hear. I think so please jot down your thoughts because, as most of you know, I could talk forever about myeloma, but need clear direction. But I think one of the reasons we had a bit of a hiatus is so we'd gone through, what do your lab tests mean? What do your imaging mean? What is a stem cell transplant? But I mean, there are certainly many individuals that are quite a bit beyond that due to their own personal experience with the disease, attending other venues, and I would benefit by direction what you want to hear about. And nothing is too simple or too hard to consider. But I feel we need direction rather than just starting over with what your blood work means, although I'm happy to do that. What is MRD? Please pass those on because I'm not even quite sure what to make the next seminar about. I mean, we can
It's
start over, but it gives direction. So please drop us a line.
Absolutely. Yeah, there are so many aspects, and I feel like you can, when you're working in the field for, a long period of time, there's obviously people who are joining that are at different points in their journey, just learning, or like you said, Donna, they're much more, experienced, learned the lingo, and a lot of the terms and things like that, and just immunotherapies, how they work, and other people are just getting introduced. And so everyone's at a different spot in their journey and background and experience. And so we definitely want what we're sharing to be informative and what you want to hear. So absolutely. Thank you so much for joining, and absolutely reach out to us, and we will keep you guys updated on future webinars. But thank you so much, Dr. Reese. Fantastic presentation going through all of these incredibly complex studies, difficult abstracts, very complex field. Super informative. We had a lot of messages throughout the chat saying thank you. So I just wanted to share that with you as well. But yes, thank you guys so much. And we will see you at the next webinar.
Yes, and we'll be a little more organized. Thanks to Jan Vlugel for passing the word out to the Toronto support group at the last minute. We'll get a little more organized. So everyone have a good warm evening, and thank you so much for taking the time out to attend. Good
Thank
night.
you. Bye.
Bye.